Hi, everyone. Welcome to another episode of 10 Minutes with JPIDS. I'm your editor-in-chief, Ravi Jhaveri. Really excited to have two of our colleagues here from Mass General Hospital, Chadi El Saleeby and Vandana Madhavan. They're going to discuss a recent article we published about the eConsult process and the initiative that they've taken. So first, thanks both of you for being here with us.
Thanks so much for having us.
Yeah,
We appreciate the invitation.
Absolutely. So our listeners know that I start every podcast the same, which is I admit that I'm a superhero nerd, but to know that every superhero has an origin story. And so I'd ask both of you to please share your infectious disease origin story. So Chadi, you're on the top of my screen. Maybe we'll start with you.
I was going to run and get my cape, I think.
Yeah, okay.
Maybe not. First of all, thank you again so much for inviting both of us. It's nice to just, interact over like this platform. It's novel as e-consults are, so we appreciate it again. My story is actually not too very complicated, but I'm like an international medical graduate. After I finished my residency at the American University Hospital at the American University of Beirut, I came here for fellowship at St. Jude. So between St. Jude and the Bonner Hospital at Memphis, Tennessee, I spent like 3 and some years, doing infectious diseases fellowship, but also a master's in biostatistics. And after that, like all IMGs, unfortunately, they needed to repeat like a little bit of their training. So I came here for residency in 2006, and I've been here since. And just for the record, Vandana interviewed me, as a chief resident. So, thank you, Vandana, again. I think you made a good choice. I'm not sure, but, I'll let you decide.
Yeah. Well, she obviously recruited you to help with this project. So the two of you are working well together. Vandana, what's your origin story?
So my ID origin story starts not very far from here. I went to Harvard undergrad, and for my honors thesis, worked in an adult ID lab.
Okay.
And that's when I started thinking about clinical ID. I was already pre-med, going into medicine, thinking about pediatrics, and met a lot of ID clinicians. And what I loved was when I asked, like, what drew you to ID? It wasn't something, super complicated. Oh, I love how the kidney works, or I love like calcium metabolism. It was like, it's just neat. It's just cool, which made me want to learn more. I went to University of Virginia for medical school, which is an amazing ID department. So got to do more work there in Brazil and during residency. And then I came back up here for chief residency, as Shadi mentioned, and then did fellowship across town in Boston Children's, and, developed a mostly pediatric ID with a little bit of primary care and general pediatrics
Awesome.
education work as well.
Awesome. All right. Thanks for sharing. That's always my favorite question to ask. So maybe let's start with how this eConsult initiative got started and sort of how you got the ball rolling and what ultimately led to sort of the phase that you guys published in the most recent paper.
Yeah. Well, maybe I can start there. So Mass General had been developing a asynchronous eConsult program to help with a burden of outpatient clinical referrals, to help with asynchronous specialist provider to referring provider, often primary care, but often other specialists as well. And it started this program, and in 2018, we were tasked in pediatrics with, hey, a lot of other departments at the hospital are doing this. You need to set this up as well. And so we, very carefully, developed it from, soup to nuts, borrowing, standardized, language, disclaimer language from others, but really developing templates and order language, et cetera, that were really specific to our division. And when we realized how much it had grown, we realized it was a really good, time for program assessment. So we looked at referring provider satisfaction. We looked at the actual content delivery, so to speak, and what services we were providing, and then looked at what our provider experience was as well. As the service grew, and obviously as telehealth as a whole grew during the pandemic, a couple of years after the onset of our program.
Yeah, our program at MGH, I think, we have started, at least in the intensive care unit, we've started decades ago. Actually, this dates back to 1998, if I'm not mistaken. And, the formal telehealth program at MGH has started in 2011. So, long before the COVID and long before this became like a la mode, we've been doing this for quite a while.
Yeah.
And I have to say, for us, the launch was not as problematic as, in places where you have like no template, no foundation, no specific expertise. Ours was not that complicated. I think we built on the expertise of a lot of other folks and the expertise of MGH telehealth per se to build up the program. So that part, although, clearly, complicated and assiduous at times, was, much, much less problematic than in other places.
And when Vandana, you mentioned that you guys sort of did that assessment to sort of see where the program was. Can you, so many of these, what we sort of consider big changes in how we practice are often big cultural shifts, right? And so can you maybe share some of the feedback you got from those providers about maybe the culture change that was required or that they were still sort of in the midst of as you were expanding the eConsult model?
Absolutely. So in terms of the referring provider model, we were really trying to shift what was a lot of informal curbside consultation, so to speak, someone paging the on-call doctor, doing a telephone call, maybe even asking us to look into the record, et cetera. But of course, there was no written documentation there. And so we're really trying to codify all of that on both ends. And so it was really for better education and protection, so to speak. And so I think, while there was a culture shift in that, like, it wasn't just a quick, like, hey, let me page, get a call back and, write down some notes. It was like, actually, can you go into Epic? Can you put in this order? And hey, this might take a little bit longer for the overall workflow. I think on both ends, it was, hey, you're going to have something written to refer back to. You don't have to worry about taking notes. If somehow we call you back in the car, you're going to have something there that maybe you can show the parent. You can have references that we're sending. It's a little bit more detailed, et cetera, be able to use for similar patients in the future. So it's a real learning opportunity and teaching opportunity. But for us, it's obviously protection as well. And so that was a huge thing to make sure, as I mentioned, using the disclaimer language that other eConsult programs had used to make sure is very clear that we were not seeing the patient. We were only reviewing a set, part of the chart, and that there was a clear kind of off-ramp, so to speak, that we felt that the question was outside the scope of an eConsult. We could still say, you know what, we need to see this patient.
Right. Chadi?
There was a lot of deconstruction, as Vandana mentioned, like in the olden days, a PCP would like automatically, go to the paging directory and page us for like, hey, why do I make about like those EBV, viral loads or like, serology panel. Yeah. So a lot of like deconstruction needed to just get ingrained into the system.
Yeah.
And now we have like, a fair amount of folks who just, immediately go to the system, get the eConsult going, and then don't think about it. Clearly you become more and more proficient about a certain system the more that you use it, clearly. Yeah. So, we have like, high value users or recurrent or frequent users that we see like, the names pop up like, maybe once or twice a month, so to speak.
Yeah.
So
it
was great.
Sorry to interrupt. One other, I guess, question I would ask in follow-up is, in the current era, and I'm not sure if your EMR is set up the same way ours is, but, our institution has basically made it so that almost every note is findable by the parents in the MyChart feature or the home parent feature, whatever. Have you also had feedback from parents about the content of eConsults or the back and forth, but maybe good or bad? And if it's really bad, we can leave it out. But I'm just curious. I think the expectation for transparency on the patient side is obviously very different than it used to be. And how do you feel they react to the eConsults?
I don't think we've had like any feedback from parents, Vandana. I think maybe that would be like, publication 2.0 going forward. We've definitely had like feedback from users, like providers who actually ask for the eConsults. We've had like, internal, provider survey per se, like, ourselves, also like, looking into feedback in our own, like, expertise and the way how we apply this and the shortcomings of it and how we can make this better. But I think from families, I don't know, Vandana, if you've heard from any families.
I have not directly. We've had a lot of great feedback about our patient to provider virtual consults, obviously, and we've recruited that formally and informally. But in terms of these asynchronous e-consults, it's a great point. I think it's been more a roundabout way of feedback where in following a patient or, when doing these chart reviews, I've seen doctors send messages through our patient gateway to the family saying like, hey, like I asked for an IDE consult, I got the recommendations back, and then they quote what we've said.
Yeah.
And so they're clearly using that. And so that, even though we're not tracking that per se, it is nice to see that, our time and crafting patient, centric recommendations, references, et cetera, is being used.
Yeah.
One thing I would add also is that, when we analyze the content of the e-consults per se, we did find that in about 20% of those, consultations, we had like a patient directed specific recommendations, either educational materials or like places where the parent can go. So your question is on point here, how does the family react to it? And again, while we don't have like, a formal form of feedback, I think it's something to experiment with and then look into in the future.
Yeah. I mean, you can probably see if those links are being accessed, right? You can with your informatics team. So maybe that's paper 3.0 now. You're already talking about several other papers. So, as we talk about trying to promote the value of ID across our specialty, I'm just curious if you guys could talk about progress in making these billable visits. I know when it was initially structured, it was talking about sort of managing patient flow in what might have been a crowded system. Can you talk about the status of billing with e-consults in your system, and perhaps sort of talk about more broadly what you've heard nationwide?
Yeah, I can start. So I will say that we were privileged in a number of ways. One is that we were developing our own program, but within the, under the aegis of, the larger MGH program. And since that program's onset, the larger program's onset, and ours even to this day, it's e-consult reimbursement is direct to provider through our physicians organization, because they have wanted to support this program so much, because it does theoretically open up access to more in-person visits, provides our service to an ever-growing network. And so we get a certain dollar amount. If you're gonna, I don't know if you can include extra, actual dollar amounts, in this, but
you can probably leave the specifics out, but maybe you can.
But it's a little less than one WRVU, per e-consult, and that has not changed since the onset.
For 15 minutes to 30 minutes of work, Vandana, we should probably add,
Right.
Okay.
Right. And so it's equivalent, a little less than, one WRVU, but this is tallied outside, there's no e-consult requirement in our WRVU targets or our, salary sheets, et cetera. And so, and those participating providers, every quarter get an email saying like, you did X number of e-consults, this is how much will be in your next next paycheck. And so we have been lucky that it's like a separate, still supported program. But on a more global level, there's definitely, with the rise of telehealth, even though as Chadi mentioned, we've been doing it, these telehealth initiatives well before the pandemic, because of the rise of telehealth initiatives, more insurers are paying for direct provider to provider consultations, even phone calls, et cetera. And so that's something that more and more programs are looking into. We haven't done so yet because we are still in this protected space.
It's also important to mention, I guess, that, our study did not formally, evaluate the impact of the finances of the entire program. Well, you can argue that this can generate, more income because, clearly you bill for those visits, but also you generate sometimes, in-person visit for your own, inpatient or in-person rather versus, official ID consults, but also to other subspecialties. But how many do you take away? Some of those may have been, otherwise dealt with as a formal visit. So I think that balance, it's just hard to tell where the scale tips. Does it tip, financially on a beneficial side versus otherwise?
Yeah, for sure. For sure.
And we also, we thought about this because this was a question that, came up is, is there an impact on our outpatient volume? But at the same time, as this program has expanded, our referral network and the larger, hospital enterprise has also grown. And so the number of referrals in general has grown. So it's really been hard to figure out the direct impact or even indirect impact of e-consults per se.
Okay. All right, maybe just the last question is, what advice do you have? Obviously, many programs are looking to get either e-consults or interprofessional consults or some sort of technology-based consulting system together. What advice do you have for them as they get started?
I think setting expectations on both sides, on both the referring provider sides as well as the PDID physicians as well is really important. I think in terms of our side, I think being realistic about how long, these consults actually take. Often we want to, have references, look things up, et cetera. So it's not really a quick like, hey, I have 5 minutes before my next patient shows up. Let me knock one of these out, but really having some dedicated time to do them, to do a good job. So really important to think about how the staffing is going to work, et cetera. Our staffing model changed, over the years. And so, when we recruited our most recent feedback from the group, definitely there were different comments from those who, who were completing them and those who weren't. And I think on the ordering provider side, we've gone through a lot of iterations in terms of how the order itself looks in the system to set really clear expectations that this is not like if you have an urgent question, nothing, supersedes an actual, doc to doc, phone call, timely communication. And we've actually extended our turnaround time, given that that was our one piece of negative feedback in our initial provider survey, that our turnaround time was long, but we realized that we were actually trying to promise more than other divisions were.
Right.
And so we needed to manage those expectations better.
Okay.
And maybe in a more regimented way, like we have like a 10-point, I think last time we, wrote an article for JPIDS in 2021 or 2020, I believe, for an invited review. I think we had like we had outlined like a 10-point, system, how to, start like an infectious diseases telemedicine program. So, all these are like, outlined in a sort of rigorous way. We encourage you to look into that one.
Yeah. Yes, definitely. As editor-in-chief, I encourage you to look at both articles, the first article, the review you mentioned, and then the more recent one. In the last minute or so, any last comments or points you want to make? It's
a lot of work to start with, but then when you get into, the train of it, becomes like much less problematic. Yeah. And if you are thinking of doing something like this, just realize that when you are on service, in the ICU, seeing somebody and like your pager going off like 10,000 times, completing an e-consult, it's probably not the best way doing it. Okay, so have, your inpatient with one specific call system and your outpatient slash, e-consults in a totally different call system.
Yeah, I think really, even if there's a push to get one started really quickly, really thinking about, managing those expectations. I talked about really thinking about staffing and really being honest about how much time this is going to take to provide a good service. Because again, we got great feedback from, providers formally when we did a survey, but also informally, and we're into people who are like, oh, thanks so much for that e-consult. That was great. I passed this along, or like, I bookmarked this patient so I can refer back to that e-consult for XYZ, advice, et cetera. And so it's worth the time to really set up, these workflows and thinking through what might be your particular problem points. For us, like staffing is certainly an issue as a smaller division, but maybe for larger divisions, thinking about, is there going to be protected time to do this that takes away from other outpatient work, et cetera. And so really about what might be particular challenges to really set up a really great program.
PDSA cycles. PDSA cycle.
Learn.
We've done like 1 million of those, I think, in the last 7 years.
Yes,
understood. It's so much ongoing process improvement in the last 7+ years for
All
this
right.
program.
Well, Chadi and Vandana, I want to thank you so much. One, for joining us today. Two, for publishing your work in JPIDS. We look forward to, papers 3.0, 4.0 in the future. And with that, I say thanks to our listeners. We'll see you again with our next episode.